Hey everyone, I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination here at the Task Force for Global Health in the United States. It's my pleasure to welcome you to a webinar to engage all of you in a discussion regarding an operational research roadmap to simplify hepatitis B screening, linkage to care and treatment in low and middle income countries. This roadmap was put together by many experts in hepatitis B care and treatment in Africa, Asia, and South America, including the United States, over 2023. The roadmap was released in 2023 and in December to really lay out some priorities of why a research roadmap is needed. Next slide, please. Just for housekeeping, this is supposed to, as you'll see here in a moment on the agenda, this will be very discussion-rich webinar, and we look forward to all of you viewing the webinar to provide your comments and questions in the chat function. And we'll do our best to answer the questions as well as to incorporate some of your comments into the discussion. The webinar is being recorded and will be available on our website at globalhep.org, along with other webinars that we've hosted over the last 4 years, as well as the slide sets will also be available there. And while you're at globalhep.org, I encourage you to sign up for our newsletter so you can get regular updates about upcoming events from the coalition. Next slide, please. Just wanted to begin to introduce you to the roadmap that was put together. As you'll be learning more about, we really spent a great deal of time focusing on where is the evidence the thinnest in directing feasible models of care for low and middle income countries, and how could those be improved. The importance of engaging the national health officials in those discussions so that you can bring all the stakeholders to the table. The recognition that research centers are very small or even non-existent in many low and middle income countries, and what's the role of a roadmap in strengthening that research capacity was put together. And then all of that needs to be brought together to inform policy development and program development so that you can actually scale up access to screening, care, and treatment in low and middle income countries, which is your ultimate aim. Research should be information for action, and that's your last final critical step. And so the roadmap sought to put all of those different elements together so that we can have the impact that we are seeking for a large, neglected global health problem, which is hepatitis B, that causes hundreds of thousands of deaths in low and middle income countries every year. And those can be prevented with better access to screening, care, and treatment. Next slide, please. For those of you who have not yet seen the roadmap, it's available on our website. You can use this QR code to get that to get access to it, or again, simply go to our website at globalhep.org. Next slide, please. This is our agenda today. I'm about to turn it over to my colleague, Dr. Neil Gupta, who helped bring the roadmap together. And then we'll be hearing from a variety of individuals who participated in putting the roadmap together to look at the 4 priorities that the roadmap puts forward to expand access to screening, care, and treatment. And then we'll have a panel discussion from individuals coming from different perspectives of the roadmap and where do we go from here. Next slide, please. So without further ado, I'll turn it over to my colleague, Neil. Neil?
Great. Thank you so much, John. And good morning, good afternoon to everyone on the line. Thank you for joining. Good advance to the next slide here. My goal today is to introduce you to the objectives process and key priorities identified in the operational research roadmap to simplify Hep B care in low and middle income countries. Hopefully everyone's had a chance to download and take a look at the report themselves. If you haven't, highly encourage you to do so while I'm speaking so that you can follow along from the report as well. But I hope to hit some of the highlights and introduce those who haven't had a chance to see the report to some of the key themes of the report. Thank you. Next slide, please. So just by way of a very brief background, I think everyone on the line knows the immense burden of hepatitis B globally that we're facing. Over 300 million persons living with chronic Hep B infection globally. And one of the key themes within the epidemiology of hepatitis B is the disproportionate burden of hepatitis B in low and middle income countries. 87%, according to the WHO Global Progress Report in 2021, 87% of the global burden being in the African, South Asian, and Western Pacific regions. Next slide, please. Now, in establishing the elimination goals for 2030, the initial models published in 2016 showed that even with high coverage of prevention measures, including antiviral prophylaxis and Hep B birth dose and primary series for neonates and young infants, there will still be over an estimated 1 million deaths per year from 2040 to 2050. So really a tsunami of morbidity, mortality from hepatitis B globally. And to achieve mortality reductions to the goals of 65% decrease by 2030, the initial models included 80% treatment coverage needed with 95% assumed adherence for linkage to care, treatment, and retention in care. So very ambitious targets and goals, and embedded in those key assumptions of treatment coverage and high levels of adherence that we need to achieve. Next slide, please. I think we all on this call know that we are far from achieving such levels of coverage. Globally, this is the 2021 Global Progress Report from the WHO, showing 10% of all individuals diagnosed and 2% in care or treatment of those needing it. And you can see those numbers are even lower in some of the regions represented by primarily LMICs, including African region and the Southeast Asia region. Advanced slide, please. And we know, and we have the opportunity to hear from our WHO colleagues later on this call regarding the hepatitis B guidelines that will be published very soon. We know that within those guidelines, expanding hepatitis B treatment criteria, simplification of treatment criteria with more people eligible for treatment will actually put additional pressure on already under-resourced health systems and LMICs to achieve target levels of coverage and to ensure that all eligible individuals can actually be linked, initiated on treatment if necessary, and retained in care over time. Next slide, please. So here on the left side is a series of implementation strategies that have been proposed to improve hepatitis B care and have been implemented in certain areas or by certain teams across the care cascade, from diagnosis, assessment, linkage to care, treatment, and adherence and retention in care. And we have strong examples of intervention strategies, not only for hepatitis B, but those that we've learned from the good practice principles for HIV and hepatitis C as well. We do need, for hepatitis B, strong evidence-based models of care delivery that incorporate these implementation strategies specifically for hepatitis B. And the premise of this operational research roadmap is that a benefit of establishing strong evidence-based models is that operational research needed to really demonstrate those evidence-based models of care can facilitate learning while doing, or establishing evidence and demonstrating implementation strategies while actually rolling those out, not waiting decades for the results of long-term trials or studies, but rather learning in real time. And that was one of the key themes that came out during this operational research roadmap process. Next slide, please. So in this report, what we set out to do from the very beginning was conduct key informant interviews and focus groups, then conduct a rapid scoping review of operational research in LMICs, really to identify gaps in the literature, and then conduct an expert workshop, which we held in May of last year, which brought together many of the speakers that you'll hear from today. Next slide, please. So in conducting key informant interviews with 14 operational research leaders across the world, as well as a focus group that was conducted at the APASL meeting in January of last year, we drilled down on research needs that were really expressed by operational research leaders in the field. So community and policymaker awareness were key themes, healthcare provider awareness, training and mentorship, decentralization of services were really required, and integration of Hep B interventions within primary care were identified as a key need within health systems. Of course, enhancements for health information systems and strategic information were listed as a key priority qualitatively from these individuals. In the bottom left, you see here access to diagnostics and medications, including availability and financing or payment for payment schemes for individuals to actually access key commodities, diagnostics and treatment for hepatitis B. Then on the top right here, you see an area around new technologies or the development and validation of point of care, HPV diagnostics, biomarkers, establishing readiness for functional hepatitis B cure, as I think many of our speakers will speak about today. And then finally, an area in the bottom right, which is not as much of a research need, but really a facilitating factor for conducting such research, which will include building capacity for equipment, staffing, training, and data and health information technology systems within LMICs to really ensure that operational research can be conducted. Next slide, please. So a real brief snapshot here on what we learned from our scoping review on operational research in LMICs. We looked at the last 10 years of operational research published in the literature on major literature databases. You can see the detailed methodology on our website. The link is at the bottom left here, but it's easily searchable on our website around the hepatitis B roadmap. But a quick snapshot here of what we learned. We found 56 studies over the past 10 years from LMICs, putting aside literature from China to be analyzed separately. And we found major gaps in the published literature, really describing and evaluating interventions to simplify hepatitis B care specifically. And we found those in screening and assessment to linkage to care, in treatment, in monitoring, and also cross-cutting across training, education, community awareness, availability and access of commodities, and financing and policy requirements. So really, and I won't read through each one of these here, would point you towards our detailed methodology and results on our website, but really reaffirming and reestablishing what the key informants qualitatively expressed as key needs for operational research in the coming years for hepatitis B. Next slide, please. So with that, I'm going to ask my colleague, Alex Stockdale, to come on and describe some work that he was conducting along with the WHO Hepatitis B Guidelines Committee to look systematically through the global literature for hepatitis B interventions and strategies for care. So Alex, thank you so much for joining today, and I'd love to pass over to you to share your slides and tell us a little bit about what you learned with the global systematic review. Thank you very much.
Great. Thank you very much, Neil. Thanks for the introduction. So I am a physician. I worked in Malawi for quite a few years, and I'm going to be presenting data from our systematic review commission and funded by the WHO to support the WHO guidelines process. So we were specifically tasked. Let me see if I can advance this. There we are. So these are the contributors, predominantly colleagues in AIMS India, Harvard, and WHO. We aimed this review process to look for evidence in the literature of different models for how to deliver hepatitis B care. And specifically for this talk, I've been asked to concentrate on low and middle income countries. We tried to look for evidence on the outcomes across the entire span of the HBV care cascade, that is from diagnosis to being assessed for treatment, for starting on treatment, and then for being retained in care and followed up. So that's the entire span of the care cascade. So there's several steps along the way that we evaluated. And then finally, to look at whether we could identify any association between these different approaches that have been described and the effectiveness. So we also conducted a literature review for data over the last 10 years and applied a variety of analytical approaches to pool the outcomes and compare the outcomes. So our search identified 92 eligible studies reporting data from clinical cohorts. The majority of these were observational studies. And in terms of specifically low middle income countries, 8 were from low income and 31 from middle income. So most data are derived from high income settings. So this is a map of the studies according to the size in terms of how many participants and the type of the study. And you can see most are from hospital-based or co-managed primary, secondary care, and mostly from high income, as I said previously. And again, now this is now just concentrating on lower and middle income data, so predominantly from the Western Pacific region, particularly from China, with a smaller number of studies from Africa and very few studies from South America. If you look at the region, so a good spread of global distribution and more data coming in latter years. And in terms of high country income classification, predominantly high income. And you can see the different distribution according to the data publication on the right-hand side there. So I'll start by saying we didn't find any interventional studies, that is a randomized control trial assessing the effectiveness of interventions for care delivery among people living with hepatitis B. So that's a massive care gap. So if we think about the challenges facing us as physicians trying to care for people with hepatitis B in low and middle income countries, we've got fantastic diagnostics. We've got tests at point of care that are very effective. We've got treatment that's safe, effective, and cheap. So we're in a very enviable position in terms of physicians, but in terms of making it happen on the public health level, this is where the evidence gaps are. We don't know how to effectively introduce this in a sort of service delivery plan. So if we look at what these studies that we identified actually focused on, so the colored map on the right-hand side, the rows going down from the top to the bottom are the different studies, and the x-axis going from left to right are looking at what element of the care cascade was assessed. So that's eligibility for treatment after diagnosis, the proportion eligible for treatment, those who started if they were deemed to be eligible, those who retained in care, and then finally suppression. And you can see that the early parts of the care cascade are quite well described across the included literature. This is just for low and middle income countries. But when you get into the latter parts of the care cascade, that's getting people onto treatment and retaining care, there's very, very, very limited data. I wanted to highlight a few examples of models of care from across the different included studies. So these are some of the models of care that you'll probably hear described, because I know a lot of the authors, the senior or first authors, are present in this in the webinar today. So from Ethiopia, either Michael and colleagues looking at task sharing within a specialist care setting. From Sierra Leone and Zambia, looking at how to integrate with an NCD clinic, looking at the concept of doing mass community testing and then linkage to specialist care. Then some primary care models or community-based models, such as a pop-up community with outreach, so same-day initiation, visiting specialists with community testing, and then some other examples, such as supporting within the primary care concept, or doing community screening and then linking to liver clinics. So that's from the Prolifica cohort from Shibril and colleagues. And then there's some examples of a model of care of integrating within an HIV clinic. So there are examples out there of some innovations in terms of models of care. In terms of what were the outcomes from these studies, you can see that the linkage to care, which is defined as patients newly diagnosed with hepatitis B having an assessment of whether or not they require treatment, and that's according to the local guidelines in the area where the study was set. And you can see, for example, specialist care, very, very limited data on outcomes from low and middle income compared to other regions of the world. But the available outcomes show sufficient, substantial lacuna in terms of loss from a diagnosis to getting that assessment completed. And with some of these more innovative models, such as same-day clinics, or community screening linking to visiting specialists, some other higher rates of linkage, but some real drop-off, and particularly that's the case in primary care type models. In terms of patients commencing on treatment once they're deemed to be eligible, again, there's quite a few areas where there's a significant loss, and this was observed in across the entire global review. There wasn't anything specific to low and middle income country, but again, some of these more innovative models of care, such as the pop-up clinic, same-day test and treat models, show some promise there in terms of improving the conversion rate from being eligible to commencing therapy. In terms of retention and care, this is an area that requires a lot of focus, I think, and a lot of attention, and probably where there's the greatest lacuna in terms of the available evidence. So from this small number of studies, but this was a finding mirrored in the wider review, there's a real loss to follow-up. So between an interval there of 12 and 48, between 1 and 4 years, you could see that there's a huge loss to follow-up across an entire patient cohort. So, 3/4 of the cohort being lost over time, not returning for care. And then if you compare that with patients, specifically those who are eligible and indeed commence antiretroviral therapy, that's with tenofovir and entecavir, you can see that the loss to follow-up is much smaller, so just 25%. So there is an association that was observed in this and in the wider review of an association between loss to follow-up and whether or not patients receive treatment. Finally, if we take our global findings, so this is our care cascade from all 92 studies, you can see for hospital-based specialist care, which is the sort of what we took as our sort of bar for the standard of care, but the kind of the traditional standard. But of course, we need decentralized, we need innovative models. But this is just using this as our benchmark. You can see going left to right there, the loss from diagnosis, about more than 1/4 of patients on average for our pooled review were lost between being diagnosed and getting assessed for whether or not they needed treatment. And a lot of the loss to follow-up, for example, is in patients not getting specific measurements such as HBV DNA quantification. And the next drop-off, about 20% lost from being deemed to be eligible but not starting therapy. And then the next drop-off, about 15% for retention and care. This is specific to the patients who had started therapy. So we're experiencing drop-offs at every stage of the care cascade. And then finally, 1/3 of those patients who commence antiviral therapy not suppressing. And you can compare that with the one on the right. There's much greater drop-off for retention and care among patients who are told that they're not eligible for care. And if you compare that with, for example, with HIV, I'm an HIV physician, and the culture is very different between the two diseases. And you can see, for example, there are the much lower rates for the sort of global average for the UN AIDS estimates. So about 10-15% drop off at each stage compared to the much higher losses that were evident in our review of the literature on hepatitis B. So to conclude, we've got very limited available data from low and middle income countries, which is a real shame, and it's a real acute area of need to urgently get operational, interventional, and innovative research to answer the question which we need to know: how can we effectively deliver care in these settings for people living with hepatitis B to prevent death from cirrhosis and liver cancer? And bearing in mind that in many regions of the world, for example, in WHO Africa region, liver cancer is the second commonest type of cancer in men and the 4th commonest in women. How do we get care pathways and optimize the timing of follow-up? How do we optimize how we construct our clinics and follow patients and avoid this huge loss to follow-up? We've seen from the available evidence, though it's limited, that there is a real problem particularly lost to follow-up, particularly among patients not on treatment. So we need to evaluate some of these models that have shown promise here from this emerging literature. Overall, I would summarize by saying that we've got significant knowledge gaps, particularly in the latter parts of the cascade, and a real lack of randomized or interventional evidence. Thank you very much.
Thank you so much, Alex. This is really, really appreciate you coming on and sharing the findings from your work here. We found that the findings that you had really augmented the scoping review and qualitative information that we were receiving back from operational researchers from around the world, and really served as a validatory purpose, to establish this huge and urgent need for operational research on hepatitis B globally, particularly in LMICs. Next slide, please. One of the differences I would just express between the scoping review that we conducted and the more systematic review that Alex just described is that in our scoping review, we had a real look at operational research without necessarily having clinical outcomes or patient level outcomes. And in the systematic global review, we're really looking at the care cascade outcomes that Alex was describing. So included a few more studies in the scoping review that we conducted that then were included in the systematic review of which Alex presented there. With that framing and with that urgent call for action expressed through our scoping review, through our focus groups, through our qualitative interviews and information that we were hearing from the WHO consultation in parallel, we conducted an expert workshop that we held in May of last year, actually, where we actually physically congregated with many of the people that you'll meet on the line today, as well as pictured here from around the world. We had operational researchers, we had academics, clinicians, clinician scientists, we had leaders from the HIV movement, we had the World Health Alliance, WHO, CDC, all represented here. So really a top-notch, robust group of people who have been thinking about this challenge over many years. The goal of the expert workshop, it was a 2-day in-person engagement where we set out to identify operational research priorities and key questions for research, which I'll describe in a moment, to actually match those to potential study designs and studies that we would consider high priority to be conducted in the coming years. We assessed existing and needed research capacities in LMICs and how to achieve those. And then finally, we had sessions and panel sessions looking at opportunities and challenges for national policy and program engagement. And I'm going to give you a taste of those here on the next slide, once you can advance. But I'm also going to give a bit of a cliffhanger to the panel discussion that we'll have with many of the researchers who attended the workshop and can speak to this in their firsthand experience and why they expressed and prioritized some of these key areas. So the 4 key priorities, you can go back one slide here, just to give an overview of the key priority research areas for operational research that came out of the workshop. Priority 1 was really around simplifying delivery models to assure decentralized, equitable, and integrated access to hepatitis B testing and treatment within primary care or basic health systems in LMICs. So a large bucket there, and one that we'll dive into a little bit more in the next slide and through the panel discussion. Priority 2 is really around improving interventions to eliminate mother-to-child transmission of hepatitis B that protect the health of both mother and newborn. So looking at the family as a unit and not necessarily simply the vertical transmission of hepatitis B. Priority area number 3 was developing and operationalizing technologies for simplified hepatitis B diagnosis, treatment, and monitoring, an area that came up quite strongly in many of the qualitative interviews and focus groups, and one that we'll describe in further detail here. And then finally, priority area number 4, which was a bit different than the other 3 priority areas, but really looking at how can we detect persons living with hepatitis B at highest risk for progression of fibrosis and development of long-term outcomes, sequela of hepatitis B, including hepatocellular carcinoma. So with those 4 key priority research areas in mind, we'll go to the next slide. And I just wanted to give you a taste of what those specific research questions looked like. You can see this in the report, and I hope you can follow along with the 4 priority research area tables that we've assembled that you can see on the left side here, which really lay out potential design options that were put forward by the workshop members and some estimates of what it would take to accomplish those research studies. So is it a short or longer timeline? Would you expect outcomes, you know, in the 1-year time horizon or even up to 5 years? What kind of cost, generally speaking, might that study entail based on your experience? And then finally, the potential impact that conducting such a study could have. And you can see some of those assumptions there at the bottom of the table. You can advance for me, Quincy, and I can just describe one of those key research questions for each of these research areas. You know, within the first priority research area, which was really around decentralizing and simplifying care models for hepatitis B within primary care. One of those questions more specifically is how can hepatitis B testing and treatment be effectively provided by non-specialists at different levels of the healthcare system? So that's really looking from community to health centers to district hospitals to regional hospitals where hepatitis B care delivery is not often found in LMICs. And participants of the workshop expressed different ways to address that question, primarily around observational studies and implementation science here in the middle row, setting up observational studies where key interventions to task shift or decentralized care could be conducted and evaluated over time. Next slide, please. So in the second priority research area, and you can advance the slide here, one of the priority research questions was around how can maternal hepatitis B surface antigen screening be integrated into antenatal care with other screening tests potentially, really looking at triple elimination of hepatitis B, HIV, syphilis, and other STIs. This is an area that speaks loudly from many of the researchers that we met from the field, really looking to do this in their own setups. And again, thinking about ways that both formative research, really looking at what are some of the challenges and needs in health systems from both the provider and patient perspective in antenatal testing and screening, as well as rolling out potential multiplex testing or new strategies for bringing rapid diagnostic tests at the point of care for antenatal care through implementation science and observational studies in LMIC settings. Next slide, please. You can advance again. So for the third priority research area, again, is around developing and operationalizing technology for hepatitis B. One of the key areas that's discussed quite often, and to be frank, came up in the literature more often, was looking at point of care testing technologies, both in terms of new testing modalities that might be available, as well as operationalizing existing point of care technologies in the most desirable, feasible, and effective ways. And here, you know, we heard from many researchers about formative research using surveys and interviews for both providers and patients, as well as validation studies, both retrospective and prospective, looking at rolling out, demonstrating the feasibility of rapid testing and evaluating the effectiveness of such testing, not only in terms of comparison to gold standards, but also in terms of improving testing coverage within their health-seeking populations. Next slide. Finally, in area number 4, in identifying people at highest risk for hepatitis B progression to sequelae, severe outcomes, and hepatocellular carcinoma, setting up long-term cohorts, either prospectively, which might take much longer, as expressed by many of our workshop participants, but also pooling, aggregating, and establishing better data monitoring systems for existing information that can be gleaned from case control trials or retrospective cohorts. And Dr. Haile-Michael will be speaking to this a bit more through some of the work that they've been doing in the African setting that can speak to these questions and some of the needs that they may have in the future going forward. So with that, I'm going to kick off our first panel, if we can identify the slide. So we thought it was important to hear directly from many of the workshop participants, particularly in some of these key research areas, on not only why they see this as the greatest need, but also key research studies that are ongoing or that they would propose to be conducted in each of these areas. So just as a quick introduction, not doing justice to each of these 5 individuals, but in speaking towards priority area number 1, we'll have Dr. Yvonne Nardi from the Cape Coast Teaching Hospital in Ghana, who has been a real leader in operational research for both Hep B and Hep C in Ghana. So welcome, Yvonne. We have Dr. Janice Ong from the University of the Philippines in Manila, who's been conducting operational research around this area of integrating hepatitis B services in primary care. So welcome, Janice. Priority area number 2, we've asked Dr. Jibril Ndao from the MRC unit, the Gambia, to speak a bit on the operational research for prevention of vertical transmission for hepatitis B, and a real leader in that area. In priority area number 3, honored to have Professor Lewis Roberts from the Mayo Clinic, who has led many networks and collaborations around research for hepatitis B and hepatocellular carcinoma in Ghana and more regionally throughout Africa. So welcome, Lewis. And finally, last but not least, Dr. Haile-Michael Desalegn, who many of you know as a real champion for hepatitis elimination globally, as well as in the African region. He's coming to us from St. Paul's Hospital, Millennium Medical College in Addis Ababa, Ethiopia. So thank you all for joining us today. Invite you to come on video so that you can be seen by our audience here. So just welcoming Dr. Lewis, Dr. Jibril, Janice, Dr. Yvonne, and Dr. Haile-Michael. And we encourage everybody to put their questions in the Q&A box as well. If we don't get to them verbally, we'll ask our panelists to speak to those. So please address your question in the Q&A to a particular panelist, and we'll have them provide answers as well. So if I could start with the priority area number 1, and maybe I'll kick it off with you, Yvonne. So thank you again for joining, both here in the webinar as well as the workshop last year. And I was wondering if you could kick us off really in speaking to priority area number 1 around decentralizing care, and give us a sense of what we mean by decentralized care in your setting, and why research in this area would be important. What potential impact could research around decentralizing care and simplifying care models actually have in Ghana? Thank you, Yvonne, over to you.
Thank you, Neil, and thank you for the opportunity to speak as well. So for decentralized care, it's basically shifting care from specialist centers to lower levels of the healthcare system, so primary care, for example, community centers, urban health centers, district or sub-district hospitals. I'll give the example of Ghana, where at the moment hepatitis B care is mostly specialist-led at the larger teaching hospitals. So decentralized care would look at shifting some of the management of these cases to lower levels of the healthcare setting. And I think this is really important, and research in this area is important because we need to generate evidence to be able to influence some of the policies that are made in the country. I think we also need to be able to provide evidence to better plan budgets. For example, at the moment in Ghana, there's not a heavy budget line for hepatitis B care, so generating the evidence would be useful for that. And I think it's also important to help reduce hepatitis B related stigma, because many people who have hepatitis B may be seen at specialist centers in these larger hospitals, and there may be a fear or a misunderstanding associated with the diagnosis. So shifting it to lower level centers makes it seem as though it's more of an everyday or a relatively less serious condition, and there would be less fear, and potentially people would be more likely to get access to care. In terms of what types of operational research would be useful, I think initially starting with evaluation of existing programs, and I can give the example of Ghana, where we did the HEAT project, where we evaluated testing and treatment capacity, and we realized that, again, this care was predominantly in the larger teaching hospitals. So starting that way would help us identify whether there are gaps and where exactly the gaps are, which levels of the healthcare system, so that we know where to focus some of these interventions, some of these strategies to decentralize care and expand care. I think that other studies would look at assessing various implementation strategies, particularly in Ghana. If we look at simplified models of care, that would be very helpful, because we could potentially look at observational or implementation research where we target community health centers, sub-district level health centers, and potentially integrate some of the hepatitis care into pre-existing clinics. It's been spoken about how HIV care services, the continuity of care seems a lot better than hepatitis B. So well-established systems, adding on hepatitis B care, or even looking at antenatal clinics and adding on hepatitis B care through training of the healthcare workers to be able to manage this. So doing implementation research in these would be very useful and would generate very good data or evidence about how decentralized care is important and necessary. We could evaluate or measure the proportion of people who have been diagnosed, how many have been put on treatment, how many have been retained in care in comparison to the pre-intervention state. So yep, I hope that's a bit of a summary of why decentralized care is very important and what kind of research we could do. Thank you.
That was an amazing summary, Yvonne. Thank you so much for that. And maybe here I'll invite Dr. Janice Ong to give us maybe a different perspective, regionally speaking. Janice, you've conducted similar type research in the Philippines and Vietnam. Would love to hear from you, how that some of the operational research questions that you're tackling that you think need to be tackled, and what are some of the challenges that you've had in conducting such research and that you would want to overcome, in the coming years. So thank you, Janice, for your thoughts.
Thank you also for inviting to be a part of this webinar. I think the situation in the Philippines is pretty similar to Ghana, where we really have to generate the evidence base for us to be able to influence policy within the government. I think one of the things that to add to what Yvonne had mentioned, some of the research that we did before we went ahead and co-designed a model of care with key interventions, so a package of interventions. But before we went to that, we did some research, pretty much like what Yvonne said, was to scope the landscape of hepatitis care in the country. And then we also assess the patient journey to get an understanding of the pain points that patients were experiencing in their care, and how a patient-centered, decentralized, and integrated care delivery would be helpful for them. We're now implementing our model of care But I think the pain points are still there, and we really have to address these pain points, especially with respect to acceptability of screening, both by the patient and the healthcare provider. We also need to go back and really reinforce the treatment eligibility determination. We found that sometimes there are mistakes that are made, and going back and doing it over and over with the healthcare provider through telementoring, I think is very helpful in making sure that we reinforce what they've learned in the training, and also to reinforce the need to adhere to follow-up, as well as to the callback for the determination of treatment eligibility.
Thank you. Thanks, Janice. I think that really speaks to some of the challenges that we find operationally for hepatitis B care delivery. How do you, when you are proposing those different interventions, how do you study those? How do you, insert those strategic interventions into the care model, and then actually evaluate those? And what has the challenge been around that? I think some of our audience members might be, wondering. It sounds like it's pretty easy to, evaluate an intervention. What makes it so difficult?
Well, I think what makes it difficult is that it's a package of interventions, and so there are many moving parts, and our goal is to look at the cascade of care outcomes mainly, but we have provider and patient surveys both before the start of the model of care and at the end of the model of care. We also did a health facility assessment at the start, and also we're hoping to do it at the end of the 1 year of the trial. The other thing is that we're going to be hopefully, so that this would be really a game changer, would be to really cost out the interventions that we did in order to come up with a cost estimate, which in our country, it's very important to be able to have a package, a benefit package within the health insurance for sustainability mainly. So, the challenges are there, and we conduct quarterly quality reviews, monthly actually, within the countries, and then we're going to do retraining and implementation review every quarter.
Thank you, Janice. Really appreciate it, and walking us through, some of the steps that are needed. Let me pass this over to Jibril. Jibril, you've been conducting, prevention studies and looking at vertical transmission in the Gambia and elsewhere for quite a few years. Can you talk a little bit about what you see for the future? What is the next step that we need to take in vertical transmission research and prevention of vertical transmission in your setting and beyond in the coming years? Thanks. Over to you.
Thank you, Neil. Thanks for inviting us for this. I would just say that elimination of molecular transmission is priority number 2 in this report, but that doesn't mean it's less of a priority than anything else. If anything, I would say it's the number 1 priority, because it's the only way that we can ensure a generation free from hepatitis B moving forward. Over the years, the sad part is prevention of molecular transmission has been neglected in most of the low-income countries, and as a result, it has led to lots of new infections, and we have now realized that infections acquired perinatally from mother to child through mother-to-child infection actually leads to more severe disease in adulthood, accounts for more cases of liver cancer, which have a terribly short survival in most of the low-income countries where resources needed to manage them are not available usually. In most of our research and our work on implementation of these strategies, two things have come out as the most striking problems. And they all center around demand and supply. On the demand side, there is a terribly low demand for the uptake of these strategies that we know we have now. There is maternal testing during pregnancy should be accessible. The test kits are available as point of care. They are relatively cheap. And there's a vaccine that can prevent chronic infection. And this should normally be available, but there is very low demand for them from the pregnant women, from the community, from the policymakers. And we think this centers around poor community awareness, both from the policymakers, healthcare workers, and women. And on the supply side, there's an ineffective supply chain in the sense that there is no clear pathway to increase the uptake of these strategies within the healthcare systems. And most of them should be relatively easier to implement, but for various reasons, they are not. It doesn't happen. Oh, I thought you had a question there. I thought you were saying something.
Oh, no. I was going to say, so those are some of the clear challenges. How do you propose through operational research that we get to some of the solutions?
I think operational research questions centering around increasing awareness and knowledge, increasing community engagement in the prevention, diagnosis, and management of vertical transmission of hepatitis B is a priority. And this is a low-hanging fruit. It's relatively easy to do. It's relatively inexpensive to do. And it would have amazing yield. It would improve political will. It would improve supply of these services. It would increase streamlining and integration of services using resources that we already have. So we just need to increase awareness and find out what would work, what would not work, what is the best way to increase the demand and the adoption of these integrated delivery services. And the other key operational research question I would say is to understand how we can scale up interventions in a differentiated model of care in diverse settings. Yes, we have all of these resources at our disposal, but we do not have the evidence of how to scale these implementation models in diverse settings, from the well-developed urban hospital-based antenatal clinics to the remote rural ANCs that are manned by perhaps one community health nurse with a trekking clinic, and most of the deliveries happen in less medicalized settings. So having an operational research that aims to increase uptake of strategies of PMTCT in decentralized settings can help address some of these questions. And alongside them, we can build in other studies to understand the cascade of care outcomes, the cost effectiveness of the different strategies, and even randomized trials of the effectiveness of different PMTCT and prophylaxis strategies. Whether do we have to prophylax all the positive women or only women who are potentially at high risk by virtue of high viral loads? Do we discontinue prophylaxis after delivery, or do we continue it during the reproductive years? And what are the best practices to scale up timely birth dose vaccination, both in facilities and in home deliveries?
That is a great overview, Jibril, because I think you hit on many of the different interventions that were discussed in the workshop, and the research questions that would be associated with each one of those. Wish we could continue this conversation, but for the sake of time, I'm going to move on to Professor Roberts. And thank you, Prof, for joining. And I think you could really speak to any of these key priorities given your experience over time. But we'd love for you to walk us through what you see as in priority area number 3 as some of the new technologies or potential technologies that could really improve hepatitis B care in the African or LMIC settings overall. And what studies do you propose, or would you mentor young researchers to conduct, within their settings to improve hepatitis B care through those technologies? So over to you, Professor Roberts. Thank you.
Thanks, Neil, and thanks for the opportunity to be part of this panel. I think one of the keys really is recognizing for hepatitis B that for many healthcare workers, it's a confusing disease to understand. And that means that for the community, it's a confusing disease because they might go to different healthcare workers and get different messages back. And so if there was a way for us to simplify the testing so that we could identify those people most likely to have progressive disease of some kind from their viral hepatitis, that would be extremely valuable. And of course, that's a global challenge. And I think even in high resource settings, we have difficulty determining that there are a number of new tests that are being brought online, things like the core-related antigen tests that we're really trying to better understand to see if they would give us clues to a person's risk of progression of their liver disease from viral hepatitis B. But it looks as though at this point, we have these algorithms that encompass different elements of the disease. So we look at DNA replication, and we look at the HBV DNA levels in the blood. We look at the response by the liver, and we look at ALT levels in the blood. And then we wonder if the inflammation that's reflected by the ALT actually is causing a problem in the liver, and we have tests for fibrosis in the liver. And ultimately, we are looking to determine whether people are at risk for liver cancer, and there, for example, gene variants that they carry that put them at risk. And I'll let Dr. Disselin talk about those other aspects. But clearly, a complicated landscape. And then, there's the whole thing of the Delta virus and anti-HDV and the fact that individuals that have Delta virus are at higher risk, for example, of complications. And then there's the broader question about what we would call the exposome, the things that we're exposed to in the environment, things like fungal aflatoxin exposure that also contributes to risk. And we find, I think, particularly in sub-Saharan Africa, that we suspect that many of these factors that are measured really by different tests integrate together potentially to lead to what we see, in practice as a very early age of onset of cancer in persons in sub-Saharan Africa. And so how do we then, in a sense, simplify testing so that, there is either a minimum or an integrated set of tests that can be performed that healthcare workers will understand and be able to interpret, and even more than that, that we will be able to explain in simple ways to not only the people who live in the cities that are educated, but what I call the last mile. And Dr. Ndao was saying, the people that are out, in villages with maybe only basic education. And so the health awareness piece, I think, is critical. And but also in the research area, are there ways that are there innovative ways that we can either develop new tests or simplify the integration of the tests that we have. And of course, that means also figuring out ways to deliver these tests at lower cost so that there's better community awareness of the disease.
Thank you so much, Prof. I think you highlighted not only the innovation aspect, how do you bring these tests online, but then also how do you integrate them in care to really determine, different features or clinical features, epidemiologic features of each individual and their risk of progression. I think that's a perfect setup also for you, Dr. Haile Michael. You've been struggling with this question for many, many years now of who to treat, who in your context is the highest risk, for progression. Can you walk us through what you've proposed or thought about in terms of research and really pooling, a large network of researchers together to determine, cofactors or some of these risk factors that Dr. Lewis was mentioning for progression of disease and to severe outcome. So Haile, Michael, over to you. Thank you.
Thanks so much, Neil, for this opportunity and the coalition for the effort and the exercise that we had for this roadmap. So when you come to the hepatitis B progression to cirrhosis and cancer, just to take you back to our studies, when we do the studies in the hepatitis B cohort in Ethiopia, when we started, we have seen that the guidelines that have been used, for example, doesn't fit for the Ethiopian, and we have seen also for the other African context. When you see the gaps that the study from the consortium by Dr. Lewis has also shown, hepatocellular carcinoma is quite different because it occurs at a younger age, and it was associated with a poor prognosis. So there was no data to inform actually the guidelines in Africa to show which individuals are actually rapidly progressing to cancer. And as has been shown, this could be, as Jibril said, could it be the age at the accusation of the infection, the host factors which occur at different ages? Could it be the hepatitis B genotype by itself, or the environment that could be associated, the nutritional factors, the aflatoxin? So there are a lot of things going on that could lead to the progression of the hepatitis B. And the previous guidelines that we have been extrapolated from the Taiwan, from the REVEAL studies, were not working for the African context. So what kind of studies can be done to actually reach or to assess the hepatitis B progression? So from the hepatitis B in Ethiopian context, we try to scale it up to some extent in Ethiopia. And we have seen the different kinds of study designs which have been presented by you, Neil, the case control, the cross-sectional studies, which are actually having low impact. But same come with the team, initially with ASCARE, and we have some support to have a longitudinal aggregates of what has been done, like a retrospective and longitudinal data. And if this can be aggregated, can this be like a rapid outcome? Because randomized controlled trial in longitudinal cohort like the REVEAL may take longer time. So for a short time to start, we have coordinated with that to have the Hepatitis in Africa network. And this probably could help us to gauge some of the outcomes that could help in the progression, or that could lead us into the markers for fibrosis markers for the African context. But these are all like the tip of the iceberg, considering the 3,000 data from the HepSanet or the such collaborative data. So we are proposing to have a better, robust data to have is to establish probably a research centers that could in a long term can liaise with potential collaborators like Professor Lewis having a genetic study. Then we can have collaborators in Africa that could solicit the different ideas, proposals, and also funding probabilities, call for proposals. And then with this team at different centers, we can probably study the different outcomes that I've said that could probably play a role in the progression of the disease. And mind you, as you have said, the clinical trials probably we have like 2/3 of the new infections for Hep B, but it's 1% from the recent study clinical trials in Africa. So African involvement in these new trials, new studies, can, unless it has been done with such research center establishment, it will be difficult. So these research centers actually need an equipment, they need an expert. Training is a backbone for all these resource centers, and then supporting the laboratory, the biostatistician, the IT support, and other important infrastructures are also important in the resource centers.
Thank you so much, Haile. I know you could go on for much longer, and I appreciate you introducing those concepts. This has been a really wonderful panel. I wish we could carry this forward, but I think the partners panel that John will facilitate later will touch back on the coalition building and the network building that's required, Haile, that you're setting up here. There's one question in the chat regarding HBV genotypes that I would love maybe Prof. Roberts or Haile Michael, if you can speak to that on the Q&A just in the chat and provide a response there. But otherwise, encourage other audience members to put questions in the chat for our panelists. Thank you all for your time. Thank you all for participating in the roadmap. And with that, I'll bring this first panel to a close and pass it over to Lindsay Hebert. Thank you so much, everyone, and over to you, Lindsay.
Thanks so much, Neil, and thanks again to all the panelists. Next slide, Quincy. I'm just going to briefly walk you through the roadmap and what do we mean when we say the roadmap, the activities, the resource requirements involved with that. Next slide. So if you looked at our Hep B operational research roadmap report, you've seen this graphic probably. When we say the roadmap, this is really the main visual and call to action that we're talking about. And in developing the roadmap through the consultative process, we wanted to look at what activities are needed to stimulate, align, and sustain investments in hepatitis B research, operational research, to achieve the expansion of care that we've been talking about today. And what we heard throughout the process is that the research is very important, but it's not enough, that we need to have a learning by doing approach, that the research is a starting point, but it can't be operating in a vacuum. So we need to be investing in national public health programs and building that infrastructure in parallel, that we need to be strengthening the research centers in parallel to ensure that this work is sustained over time. And we need to be thinking about the plan to communicate and disseminate this research so we achieve the scale up that's desired in the end. Next slide. So action one of the research roadmap is about the research. This is where we included all the work that was discussed in panel one in terms of the studies that need to be done to fill those evidence gaps. We approximated that about 16 research studies over the 4 years of the roadmap would be needed across 10 study sites, 10 observational projects, 1 formative study, and then perhaps 2 RCTs for areas 1 and 2. Action 1 is about coordinating those studies. We propose building a coordinating center that could manage the funding for the studies and also ensure that learnings are being disseminated across those studies, and then implementing them and monitoring them over the time period of the roadmap. Next slide. Action 2 is really about engagement of the national public health programs, where these studies are being conducted, but also more broadly. It's about building that buy-in with government leaders and ensure that there is demand for integrating the findings of the research studies into public health practice in the long term. This action involves strengthening infrastructure in countries, the health IT, the laboratories, the clinical delivery, but also looking for ways to engage the governments in the actual conduction of the research, perhaps looking at integration of hepatitis B care with other programs. The government is the best pathway to ensuring that those integration opportunities are available, and also involving them in the real world practical assessments of the health economics of these program models and looking at cost effectiveness in particular. So we proposed, in addition to funding the research sites to conduct the key research studies, that there would also be funding available for engagement of those national governments and also for the health economics research required. Next slide. So this slide is about action 3, which is about strengthening centers to conduct the research. Here we need to look at not only investing in the research centers that are receiving the funding from the studies in the roadmap, but also long-term building that network of centers across the regions of high burden hepatitis B countries, where that research can grow over time to not only answer these immediate and urgent evidence gaps, but also answer questions that are going to evolve over time. Here we point out a need to invest in the infrastructure, the training of staff, and also building that community of practice for researchers to come and share lessons learned and best practices. This really builds on what Hale was talking about in the last panel. So we propose, in addition to the research funding received for the conduction of the research, the engagement of the national public health authorities, also funding to build that capacity. Next slide. And then action 4 is about bringing it all together. Once we have the findings from these key research studies, how can they be communicated to policymakers? How can we build coalitions that think about translation into policy change and advocacy? And how can we sustain those community of practice over time to ensure that this movement doesn't fizzle? And so we hope that we could work with all the research sites and wider community to identify opportunities for that dialogue with policymakers at the national level, at the international level, and to ensure that dissemination is not an afterthought, but planned for from the beginning. Next slide. So to start the conversation of the scale of the investments required for these activities, we put forth a preliminary budget estimates. We have a funders addendum that you'll have a QR code on the next slide where we've laid out some of the key assumptions that went into these cost estimates. And this is meant to be a starting point for conversation about how we can work together to mobilize the resources to fill these evidence gaps and ensure that these activities are implemented in the next few years. We estimate that about $24 to $35 million will be needed over 4 years to effectively implement these activities, and we hope to work with all of you to mobilize this into action. Next slide. And here's a QR code where you can go to our website where you can see the full report if you haven't already, and also download this funders addendum where we outline these key assumptions and these cost estimates. And we're always happy to answer questions on this. Thank you. Hand it back to John.
Thank you. Thank you, Lindsay. Thank you, Neil. And thank you, all the opening panelists. I want to make sure we get to all of our partnership panel here. And so we just want to welcome them all to the discussion. Let me kick it off, please, by turning to Danjuma, who is the former president of the World Hepatitis Alliance and has a great deal of experience in working with hepatitis prevention, linkage to care and treatment in Nigeria. So Danjuma, let me just turn it over to you in particular to comment on the role of civil society in the research we're talking about today. Thank you.
All right, thank you, John, and thanks to the Global Coalition for inviting me and for having us on this very important panel. It was quite interesting for us to be part of the discussion last year. I'll speak from two perspectives. One, as someone that is living with hepatitis B in particular, and also from the civil society perspective. And John, across most low middle income countries, the first thing a patient goes to the hospital is the person is going to the hospital with the hope of finding care, with the hope of finding solution, right? And most often, the patients in most of our facilities, you either leave confused or you leave with more questions unanswered because of lack of proper timing, lack of education. The clinicians will not have enough time to educate the patient, multiple diagnoses, investing on multiple tests that the patient needs to run. And you go to different healthcare workers, they give you different interpretations, different perspective to the condition you have. So these are issues that I think sometimes constitute a problem to patients accessing care. So the lack of awareness and lack of education is a very big barrier that needs to be addressed. And these are things that where the civil society can come in, John, and where because we are there at the community, the patient spends less than maybe 1 hour, less than 5 minutes with the clinician and goes back to the community. And most often the patients are left to their own fate to go and search for information, and most often go to the wrong sources to get information. And that is why civil society are there to break down those barriers, the cultural barriers, religious barriers, and also some aspect of lack of knowledge and awareness. Sorry, I have to switch off my video because I have lighting problem here. So some cultural barriers or myths and misconceptions, that is a very crucial role civil society play, because through peer support, through peer navigation, through peer information, is very important, because as a community person, we build trust with the community. We are in the community, and we, especially as people with lived experience, are there as patients. So we share our story. I remember when I shared my story, John, it was a stimulus for many patients to break down stigma about hepatitis. So people feel more confident when they engage with peers and they speak with peers. So civil society will play a crucial role in breaking down some of the structural barriers that limit patients from accessing care, and also in some aspect of education and awareness, and even in the demand creation. I remember Jibril mentioned something about services are there, but there's no demand from the community. So we play a very crucial, important role in demand creation, in creating the need for people to go for the testing, and also helping to break down some of those structural barriers that exist in making patients seek for services. So, but I think it's important that maybe simplification of diagnosis, John, will be a very big way to really allay the fears of patients. You discover you go to a hospital facility, you're given 10, 15 forms, that different diagnostic forms, and the patient is more confused than anybody as to what needs to be done. So simplified testing, simplified algorithm will be a very good way to allay the fears of patients and motivate patients, all right, to seek care. And then even early treatment sometimes also helps. As a hepatitis B patient, I know the several times that I've been asked to come back, even with my knowledge, with my background in virology, come back after 6 months, come back after 1 year. You don't need treatment today, come back after this. So, and I think the guidelines then that never place more people on treatment kind of discourage many people from going back to the hospital. So many patients who prefer to access the herbal traditional medicines, who promises the wonder cure, than going back to the hospital that they will tell you, come back after 1 year. You leave the doctor, you go to the laboratory scientist tells you something different. You meet the nurse, they give you. So even in the healthcare system, the lack of coordination of information also is a challenge that I think needs to be streamlined. So training of healthcare workers would definitely help. And cultural barriers, even in hospitals, you know, someone goes and then meets people who cannot speak the language of the patient, who doesn't understand the simplified language of the patient. These are serious barriers that I think, if addressed, would definitely improve patients' access to care, and would definitely improve the treatment outcomes for patients. Thank you.
Thank you so much. And what I really hear, just the importance of getting civil society organizations engaged at the outset, throughout, they could really become a research partner, and then really help with the dissemination of the findings to increase acceptance of improvements in care and treatment. Thank you. Let me turn it over to my colleague, Mark Ghani from the U.S. National Institutes of Health. Mark has many years of experience in studies of hepatitis B, and I just wanted to get his perspectives, you know, on the roadmap, you know, and how it aligns with some, you know, the robust research going on around functional cures, and just to see how we can begin to perhaps incorporate sites in low and middle income countries in both of those research activities, both with the current treatments as targets, as well as the hopeful new treatments coming up. Mark?
Sorry, let me just mute myself there. I don't think I can get my video back on. Hopefully folks can hear me. First,
Clear.
Yep, great. So first, John, thank you for inviting me to participate on this important webinar. And I'd like to offer my congratulations to the coalition on developing, which I think is a really brilliant research roadmap. I think it's very timely and really addresses what we need to do if we're going to make any inroads into lowering the burden of disease due to hepatitis B, particularly in low and middle income countries. And I think it actually nicely aligns with the National Viral Hepatitis Elimination Plan here in the US, as well as with the NIDDK Strategic Research Plan for reducing the burden of disease here in the US. From an NIH perspective, I think the research priorities are well thought out. And as you've heard from other speakers here on this webinar earlier, I think it's really hard to say which priority is more important. In terms of transmission, obviously priority 2 is the most important, because if we don't break the cycle of transmission, particularly mother to infant transmission, we're not going to make any inroads into reducing the burden of hepatitis B. And similarly, priority 4, which addresses the burden of morbidity and mortality associated with disease in persons who have chronic infection, if we don't address that crucial part of the roadmap, we're not going to reduce the burden of health aspects related to hepatitis B. So I think they're all equally important, and we can't achieve any of the goals of the roadmap, I would say, without adequate and appropriate diagnostic testing. So I think the roadmap is each of the parts have to be addressed, I would say, in parallel rather than in sequence. Now, if I could speak maybe from the NIH perspective, what is it that we can do to try to help facilitate implementation of this roadmap? The NIH is currently conducting studies to look at biomarkers in terms of predicting outcome of disease, as well as for early diagnosis of liver cancer. We're also conducting clinical studies with the goal of developing finite therapies that can achieve functional cure or sustained loss and maintain suppression of viral replication, which is what we know we need to achieve in order to reduce the adverse outcomes of the infection. And importantly, I think this research can help inform how these new treatments might be applied to low and middle income countries. You've heard about the challenges that are being faced even when we have a simple cure, such as nucleotide analogs, which is just a pill a day. Some of the more novel treatments that are being developed are quite complex, and we have to figure out a way on how we can translate these complicated regimens, simplify them so that they can be applied to areas of the world where the true burden of disease exists, in these low and middle income countries, which accounts for almost 9 out of 10 infections related to hepatitis B. But I see the NIH playing also a broader role. That is really in conducting and supporting basic virological and immunological research, so that we can better understand the disease pathogenesis and the mechanisms of functional cure. And I think this research is really very critical to developing new therapies. Currently, many of the regimens that we're studying right now are largely empirical because we lack the fundamental understanding of what's required for the virological and immunological basis to achieve functional cure. So I think these are important. It's important to continue to conduct this very crucial basic research. And then I think we can also lend expertise to low and middle income countries, because I think they're very capable of doing the research at the ground level, but we can provide additional expertise to try to understand what are some of the basis for the different presentations of hepatitis B. What causes cancer? What causes disease progression? What is the role of genotypes, particularly in cancer? There's been some suggestion that genotype A1 might be more carcinogenic, particularly in sub-Saharan Africa, and also the role of environmental factors such as aflatoxin, alcohol, etc. So I think where I see the NIH, just to end, is really in partnering with the researchers to help them try to answer these questions that are critical really for achieving the goals of the roadmap. And again, wanted to offer my congratulations, what I think is a really well thought out program. So thank you, John.
Mark, thank you for those comments. You're spot on. You answered one of the questions that came up in the chat regarding the importance of looking at differences, by geography, whether it be by genotype or cofactors that can accelerate the progression of hepatitis B, liver disease, and look forward to NIH being a partner in the rollout of this roadmap. Let me turn it now over to my colleague Rabson Kachala from Malawi, who is responsible for a variety of different aspects of hepatitis B prevention, care, and treatment. And they've been doing some work in strategic planning regarding the next steps in those areas. And just want to get Rabson to comment on which research questions really come to top of mind as we're talking about the research roadmap today and the discussions you're having about next steps and what would be helpful in Malawi. Rabson?
Yeah, thank you, Prof. And all the team. Greetings from Malawi. Congratulations for coming up with this roadmap, which Malawi, as one of the low-income country, who actually benefit a lot. Indeed, it's in line with the Malawi government health sector strategic plan 3, taking us 2023 to 2030. For health research, it's in line, especially coordinating the partners in financing the health research. For us, our policy is 2% of our budget from 2023 up to 2030 is 2% of our budget. It's reserved for health research. We have a director within the ministry responsible for that, but also the Public Health Institute of Malawi. We have a directorate of a component of research, which they're working with us. So I'm happy to report that we are trying to follow up on this Malawi commitment, but also our partners working in Malawi. It's the policy is 5% to reserve for financing, as Lindsay said within the roadmap. We, apart from the activities, we also need to have the cost estimates. So indeed, the coordinating partners, it's very important. As my colleague Ada has already said, the challenge in Africa, like my colleague in Nigeria, Gambia, said it nicely well about the challenges here. So Malawi, we are actually having more or less the same challenge, but we are looking forward to this roadmap so that we build on the health research from the public institutions, the private and academic, to make sure that we have the health research adding to the new information as regards to the operation of the programming the hepatitis B in Malawi. Also, the evidence-based informed policies by 2030, when we'll be adding the having a new HSSP, that is health sector strategic plan, the new one. We need the information. We really need to have new information about that, but also monitoring these guidelines which we are using for the hepatitis B. We have the new guidelines we are using up to 2030, according to WHO and your coalition. You have been supporting us. We are working to make sure that we monitor, keep on monitoring it and evaluate it. So all that we need new information, but also chasing and accessibility of data across systems and to be strengthened to enable them be used. Like my colleague Ada has already said, the challenge the clients they might come, they should not be disappointed. We should be able having knowing that we should expect to come such amount of clients. We should actually have such amount of test tickets so that everyone should be tested. All that in heavy systems should be in place so that we should not disappoint our clients. They should be tested accordingly. So as the Malawi government, I'm happy to report that we are working with the responsible directorate in working to come up with all the necessary areas to continue with this roadmap. We'll make use of it. So maybe I can give an example for what Gambia, my colleague, presented about triple elimination, for instance.
Rabs, I'm so sorry to interrupt, but very quickly, I know that we're right up on time, but please proceed, but briefly, please. Thank you.
Okay, thank you. Yeah, so indeed we really need to through what Mark has already said as well, and also Dr. Mark said, for instance, apart from that, the issue of we have the cancer registry, ADEX. We have been working also with ADEX to make sure that apart from the other causes of liver cancer, we have also to know the hepatitis B in Malawi. We did the initial test with the registry data. We showed about 75% hepatitis B is causing liver cancer in Malawi. That was around 2018 up to 2020. But now we didn't need to follow it up. So all this operational research, we didn't need, as Dr. Mark has said, we didn't need Malawi to follow it up on all that as well. So we have equally Malawi blood transfusion service where we do the hepatitis B testing. All that we didn't need to keep on following to make sure that we follow all those tests. So operational research on all this, it's very important, John. I think.
Thank you, Rabson. I just want to interject quickly. There's a question regarding specifically about Malawi, which is, what do you see as the biggest challenge to implementing hepatitis B birth dose in Malawi?
Okay, as of now, they might have approved that we can start using that as universal, but the main challenge is financial challenge, which but I'm happy to report that our minister has already given the letter to Gavi so that they can actually assist us. So everything has been done in place in terms of quantification and everything. So the main challenge is really the resources. So we are appealing to the global village to assist Malawi. On our part, we are doing all it can, but everything is ready to start birth dose. It's only the financial gap.
Thank you so much. Again, Rabson, spot on comments. Let me turn it over to Wendy Spearman, who is from South Africa, has years of experience working with hepatitis B in South Africa, as well as being very involved as being the chair of the committee to help WHO, who we'll be hearing from in just a moment, update treatment guidelines. Wendy, you also run an ECHO program to seek to educate non-specialists for hepatitis B care. As we think about research and and your engagement with primary care and other type of non-special liver specialist providers, what comes to mind for you as really important research questions? Thank you.
I think the real problem is, despite this burden of liver disease associated with viral hepatitis, and particularly hepatitis B, one of the problems is not recognized, and I think has a major impact. It's acquired from mother to child, early childhood, but you see the devastating effects in early adulthood. And patients really present you with established cirrhosis, multifocal HCC, and there's really often nothing that one can do for them. And so this burden of disease is really not recognized. And I think it relates to the really failure to understand the natural history of disease, how it presents, and education. And we really need to raise public awareness around the disease, but also healthcare workers. And if we're going to really make an impact, as we've heard from a number of the speakers, we need to decentralize this to primary healthcare. And if you look within Africa, you have some excellent centers of clinical research, clinic and basic science research, but really the burden of disease is actually often in the rural areas, where the access to care is very limited. And so, this is where Project ECHO has really made a profound effect sort of globally across many, many disease disciplines. And I think the real beauty of Project ECHO is you can actually adapt it to what you require. So you can do it at primary healthcare level, you can do it secondary, you can do it at highly tertiary and quaternary care. But I think if we're going to make any inroads, we need to actually improve the outreach in terms of primary healthcare, community healthcare levels, and importantly, midwives. I think we tend to forget about the midwives. We're often that first interaction. And so the benefit of the Project ECHO is that you have this very short didactic lecture, and you can develop a curriculum of training across over a period of 6 months, or you can actually address your didactic lectures to the underlying problem that's been presented. And then one of the things is that the community actually present cases that they have difficulty with. And it's actually the benefit is that it's actually a collegial approach, that we all learn from one another and we learn how to adapt to what is available. So we know that diagnostics are very difficult. They're often quite expensive. We don't have access necessarily to DNA, to genotyping, but I think we're able to work together to actually really encourage the diagnosis, linkage to care, and importantly, promote the adherence. And I think Philip will actually come in and show how the new WHO guidelines are going to actually improve that access to care. But I think we need to look at these community outreach programs, and importantly, which has been highlighted by Danjuma, is really involving the patients living with hepatitis B, involving the community. How do they see their needs, and addressing that? And I think unless we actually raise that awareness at primary healthcare level, at public health officials level, to the same sort of heights that HIV, malaria have been very effectively taught across Africa, we're really not going to make a difference, I think. So we really need to take it down to the grassroots level. And then I think in terms of that sort of birth dose vaccine, we need to learn from we mustn't reinvent the wheel. So if we look at the Western Pacific region, we look at China, the highly effective use of community lay workers to actually identify mothers who are pregnant, identify those who require the vaccine outside the health facilities. And we need to learn from that. And I think, we often we underestimate the simple sort of research programs that we can actually run by doing simple surveys and actually finding out what are the barriers, what are the challenges, how have actually people overcome it, and then implementing that. And then really, I think the other important thing would be to strengthen the established networks like HepSanet, like Prolifica, like the Hepatobiliary Pancreatic Cancer Consortium, which have been highly effective. And the reason they've been effective, they've actually identified centers of excellence across Africa, really reflecting different regions with different problems and different manifestations. And as a result of that, we're able to have really very good research coming out of that. I mean, if we look at the HepSanet, we've really looked at what is more an appropriate APRI score for hepatitis B in terms of addressing cirrhosis. So there's a lot of clinical data out there, and there are a lot of excellent clinicians, researchers, but we need to come together more as a group and work collegial and actually have support for that, because that requires setting up data systems, setting up the IT, actually support with statistical analysis.
So much, Wendy, that we touched on a lot of important points regarding just getting the outreach, the testing, linkage to care, the adherence to care and treatment. Also sort of forming a network of networks of how can you get the data management systems out there so you can really begin to share data from these treatment sites to really see what's going on now and what new interventions are implemented. I'm going to turn it over to Philippa now, who's been leading treatment guideline development at WHO for a number of years. We just had a question in the chat about the research to engage, to implement the current policies for hepatitis B treatment, notwithstanding the upcoming and new policies. And so just wanted to, Philippa, to give your perspectives from seeking to implement the current policies and then really doing an extensive review and engagement with partners around the world for the new treatment policies. What research priorities come to mind for you as they're presented in the roadmap? Thank you.
Well, thanks, John. I think, first of all, it's helpful to just clarify WHO's role in the kind of research agenda setting. One of its mandates as a normative agent for setting global and regional policy, as a byproduct of that, we develop research agendas, identify research gaps. And we're not research implementers. We generally work with partners to deliver research. Sometimes we do lead in research. And we have a formal process for highlighting research gaps and research priority setting. Although I would say with all the value assessment frameworks and multiple criteria decision analysis, but we largely do this in our department as a byproduct of guidelines development processes. So those are the critical events where we have all the right people in the meeting, the stakeholders, the clinicians, researchers, implementing partners, the Ministry of Health, civil society. And that is where, as we work systematically through each topic, we identify the research gaps. And I think it was very opportune that the task force was also sort of at the right time developing their research priorities. And so it's been a real opportunity to align forces. I think it's fair to say the guidelines meetings are very busy, and that discussion of the research gaps often doesn't get the time it deserves. So it's difficult to actually separate the research priorities from 2015 to now. Some of them have been migrated into the current research gaps. And I think that was from 10 years ago of what the hepatitis B research priorities were. I think what is probably useful to do is to flag how we can help the researchers, and also the key topics where we align, and some of those that have not been profiled in the task force initiative. So for us, it's not just more research, we're really wanting high quality research that's focused on the priority issues. I think, as others have said, really facilitating the forming of consortia with a good mix of the frontline clinicians, with those with strong statistical methodological skills, protocol development and governance. And there are many good examples of those consortium in HIV, and that's growing for hepatitis B, and HepSanet's been a great recent initiative. Getting the funding agencies on board, sharing these priorities with the major research funders to ensure they're captured in their own research priorities and grant calls, highlighting the priorities at different conferences to prompt dialogue, and supporting training and implementation research. I think in terms of the synergies, for me, the service delivery is really key. And what we're needing is the methodologically rigorous studies. And so I think, as Alex identified, that really we want studies that are fully capturing the interventions, the service delivery models, and capturing outcomes across the whole continuum of care. And it's not just different interventions, but different packages of interventions that's been described. I think something that's probably missing from the discussion, people have talked about different models of decentralization and task sharing. That's straightforward. But to facilitate that, we need a range of differentiated assessment, care, and referral strategies that relates to both decentralization and task sharing. And then I think we really need to do, and I haven't heard this mentioned, the evaluation of interventions already well established for the use in HIV care. Those strategies to promote and sustain adherence to long-term antivirals, and strategies to promote retention in care and re-engage those disengaged from care. Good cost effectiveness studies as an integral part of that. And then pretty much the same with the PMTCT, and particularly the new recommendations on antiviral prophylaxis for all. What are the practical implications of this? And in research terms, that means evaluating the feasibility, the effectiveness, and the cost effectiveness of more comprehensive peripartum antiviral prophylaxis strategies. Looking at studies of adherence in pregnant women, follow-up studies to look at some of the potential harms of those discontinuing antiviral therapy postpartum. And I think the areas that are probably less of a focus in the task force that is on the treatment studies, really long-term studies to show the overall impact and effectiveness of expanding treatment eligibility on all the clinical outcomes, looking at long-term data on the safety, both bone mineral density, renal function, and potentially some RCTs of antiviral looking at the treatment impact of those with a low viral load. We need more data on adolescents and children. And I think, as Mark has flagged, clearly the public health angle to the curative antiviral strategies, and also looking at some of the innovations on long-acting and injectables, although those would be the lesser priorities. So I think that's just a quick gallop through the positioning of WHO, where we feel we can support the frontline researchers, and how we align on some of those research priorities. Thanks so much.
Thank you so much, Philippa. Thank you all to all the all the panelists, touching on the role of civil society, the role of other large research institutions such as NIH and being a key partner, the role of this research, the role of research in helping develop national plans and programs, as Rabson pointed out. Wendy focusing on a range of issues, but I think also how research can sort of elevate the whole awareness and priority setting for hepatitis B by sending the message that this is important and that something should be done for this population. So I think that's the secondary gain, if you will, of having research ongoing for hepatitis B in these different areas. And then Philippa pointing out the role of WHO, and again, how research drives treatment guideline development and implementation. I know we're over time, so I think we'll wrap us up. I want to thank again our team here, particularly Neil Gupta and Lindsay Hebert and Quincy Williams for their development of this webinar and for the roadmap. I want to thank all the panelists for joining us today, including those that made the roadmap possible. I look forward to working with you all to put the roadmap into motion to accomplish our shared goal of improving access to hepatitis B care and treatment, and reducing morbidity and mortality from people infected with hepatitis B virus. Please keep in touch. Please go to our website again, globalhep.org, to access the roadmap if you haven't already, as well as to sign up for our newsletter to get updates of our coalition activities. Thanks again. Have a great day.